Hi, everybody. I'm Craig Norman, and I want to welcome you to the Oculus-sponsored terrific presentation tonight called Contact Lenses and Keratoconus from Diagnosis to Treatment. We have a terrific panel tonight to be presenting to you. We know that through the promotion that Dr. Clark Chang and Dr. Andy Morgenstern are involved, but we also have a surprise guest as well to add some terrific knowledge to this evening. Let me first start by introducing Dr. Chang. For those of you that haven't met Clark or heard Clark or seen Clark, he has an extensive amount of experience in specialty contact lenses and cornea. He has served as a keynote speaker all over the U.S. and on international scientific symposiums. He's an advisory board member for the IKA. For those of you that don't know that, that's the International Keratoconus Academy. He's part of the GPLI as an advisor and also the OCCRS. And to top all that off, Clark was selected as top doc of the 2020 National Keratoconus Foundation this year. Congratulations to you, Clark.
Thank you.
We also have Dr. Andy Morgenstein. Andy's the founder of OCUSolve, which is a healthcare and management consulting firm. He's a clinician with a ton of special interests, including anterior segment ocular disease, refractive surgery, corneal ectatic disease detection, diagnosis, and treatment of refractive error, both surgical and non-surgical. He's a graduate of Boston University and NOVA, and completed additional training at the renowned Bascom Palmer Eye Institute. And additionally, Dr. Morgenstern has provided eye care for members of the first family of the United States, FBI directors, NASA administrators, senators, and a bunch of other types that are make up our political force in the U.S. And the surprise guest tonight is Dr. Bill Tullo. I think many of you have seen Bill or looked at and read his publications. Bill is the Vice President of Clinical Services for VGH Holdings, TLC, and LVI Laser Centers. He additionally maintains a private practice in his hometown of Princeton, New Jersey, and has for over 30 plus years. He has worked in academia as well and has achieved a number of honors throughout the contact lens field based on the more than 500 optometric and ophthalmological meetings he's participated in around the globe. Fellas, thank you so much for spending time with us this evening. I think our audience is really extremely happy that you will take time out of your busy schedules. And to kick this thing off, Andy Morgenstern, can you please get us going tonight?
Excellent. Thanks a lot, Craig. I appreciate it. Thanks for having us. This is a topic that's pretty near and dear to all three of us. We've worked together for many years within the same groups, outside the same groups, and we've actually developed societies together around keratoconus. And it's always a pleasure and honor to speak with Clark and Bill. Clark, I put your disclosures up here. Is there anything that you need to add to this list at all?
No, that's it. Just, we're trying our very best to be completely objective tonight as much as possible.
Yep. And so I have to, because I do work with the government, I do have to let you know that I'm the optometric subject matter expert for the United States Department of Defense, the Defense Health Agency Vision Center of Excellence, where we work with eye trauma and vision dysfunction associated with traumatic brain injury. I do want to let you know that this is my personal opinion only. All materials were acquired from the public domain. Any information in this presentation is not the opinion of the United States government, Department of Defense, Defense Health Agency, Department of Veterans Affairs, or Chenega Health Services, and I was not paid for this presentation. And Bill, your disclosures right now?
Yeah, you can see my disclosures right now up on the slide. I have absolutely no disclosures. I'm currently working in private practice, and I'm currently not employed by any entity related or not related to this presentation.
Excellent. All right. So the three of us, you can see over here, I put up that slide of the three amigos. There is a fourth amigo that we typically work with. The four of us really developed this organization after I developed something called the Optometric Cross-Linking Society way back a long time ago. Barry Iden on the right over there, who's a past president of the AOA Cornea Contact Lens Section, developed a group called the International Keratoconus Academy, and with Clark and Bill, we actually combined it all together to raise awareness and education about keratoconus throughout the world. And it is truly international, and it's truly eye care professionals. As you can see here on our executive board, we have lots of OD names that you're very familiar with. We also have Eric Donenfeld and Jeroen Rabinowitz. Jeroen Rabinowitz is the ophthalmologist out in California that you may have used his technique of estimating keratoconus patients if they're suspect or not by using his superior method of keratometric readings. So the mission of IKA, and this is where we're all, this is the group that we really want to expand, even though it's pretty big already, to promote and develop the knowledge base of awareness of state-of-the-art pertaining to the diagnosis and management of keratoconus and other forms of corneal ectasia. Further, we want to promote the awareness and understanding of the most appropriate and effective treatment strategies for the management of diseases. And the question that we had to ask, here's our medical advisory board, optometric, and our ophthalmologic, both in the United States and international. And as you can see, Craig and Pat Caroline, who are on our medical advisory board as well as allied health professionals, and Mary Pruden from the National Keratoconus Foundation. Our goal with this organization was to really educate as many people as possible, because as you'll see throughout the presentation tonight, there historically has been a tremendous amount of confusion of what keratoconus is, what ectatic diseases are, what proper treatment is, and really there's never been an established consensus on all of this. But as we learn more and more about keratoconus, one of the things that we've realized is that other than using contact lenses and hoping for a patient to not require a corneal transplant, we actually have a new treatment mechanism now for it that Bill and Clark will get into. And so there's qualifications for those treatment mechanisms, and we want everybody to be on the same page so we can identify and diagnose this disease. And we're going to show you why and why it's so important. So the objectives tonight are going to be just really to look at the cornea itself and the disease of keratoconus. How do you properly assess a cornea for their disease? What are the surgical procedures involved? And really, what are the best options for contact lenses with keratoconus and ectatic diseases? And really, where is the future going? And then hopefully we'll have some time for questions and answers. So I think the most important thing that we need to look at, and I would hope that my colleagues would agree with me. I think we do, because we talk about this all the time. You really can't understand a disease until you really understand anatomy. And that's why when we're in school, or when any health professional is in school, you have to learn anatomy before you learn physiology, and you have to learn physiology before you learn pharmacology. You have to know where everything is first and what it is, because once you know what it is, something can go wrong with it. And so here you can see a histological slide of the cornea. You can see on the right side, obviously this is a vertical image of the cornea. On the right side, you can see the 5 to 6 layers of epithelial cells. You can see the majority of the cornea being stromal tissue, the collagen stromal tissue that's layered in that lumber-like formulation. You can see Decimase membrane all the way to the left as a lighter basement membrane, and then the corneal endothelium as that purple stain all the way far to the left of this image over here. And the one thing that I want to kind of point out to you is that the disease of keratoconus takes place, if you're watching on your phone or on your computer right now, it takes place from the right side of your screen all the way to the left side of your screen. The disease of keratoconus is not just an anterior curvature problem. The disease of keratoconus is histologically speaking, a disease of every layer that you're looking at right now, from anterior side of the cornea to the posterior side of the cornea. So here's a beautiful OCT image of a keratoconic cornea. And the question here is, why does this occur? Well, one of the things that I want to point out to you is, if you look at the endothelial layer of the cornea here, you can see that the endothelial layer is pretty universally thick all the way from the right side of the image to the left side of the image. One of the things you can see here is that the epithelium is, well, it's not universally thick. It's actually a little bit thicker in the periphery and a little bit thinner in the center, but not that much. But really, if you take a look at this cornea, the thinnest histological layer of the cornea in this disease of keratoconus is absolutely the stroma. And that's really important to understand, because when we talk about treatments of this disease, we're going to talk about treating that layer of the stroma, not the epithelium and not the endothelium. So just keep that in mind. Why does keratoconus occur? Keratoconus occurs because that corneal stroma is weak. And it's weak for a couple of different reasons, and it's different for every patient. It can be weak due to surgery, where we've taken too much tissue away from the cornea. It can be weak because genetically the patient is predisposed to having collagen that is just not able to really withstand the forces of the intraocular pressure of the eye. It's just weaker tissue. Or it can be environmental, where you hear of patients that rub their eyes too much. That can actually weaken that tissue as well. All of these patients, and one of the things that I think it's always important to understand is that you can't really put every single patient into one box where their only cause of their keratoconus is because they rub their eyes, or it's only because it's genetics, or it's only because they had surgery. You can have a patient that has a thin cornea due to surgery or trauma that actually rubs their eyes a lot, and you can have two mechanisms of action that cause this to occur. So I think really we have to take a step back with all of these diseases. If we're going to take a real good research look at this, is to understand the prevalence and the incidence of keratoconus, because we want to know the scope of the problem. Well, what do I mean by that? Well, if you have a primary care practice, and I told you that 30% of your patients are going to present with diabetes, you better, be on the lookout for diabetes. You also better understand diabetes identification and proper treatment of diabetes, because there's going to be a lot of patients coming in. Also, as a doctor, you're going to be more sensitive to looking for that disease if that's the population, if that's the incidence and prevalence of the disease in the population of patients that you're seeing. But what if I told you that the incidence and prevalence of a disease was 0.01% in the population that you were looking at? Well, it really is not going to be up high on the differential diagnosis list. So it's important to understand with any disease, the prevalence of it and incidence of the disease, to understand why and how you should be on the lookout for it within your practice. So here's a great picture, just to, if you want to remember what prevalence and incidence is. Incidence is the number of new cases of a given population. So that's the new water coming out of the faucet into the bathtub. The bathtub is the whole community. The prevalence is the number of patients that actually have the disease at any given point in time. It's the water that's sitting in the bathtub. So the new water coming in is the incidence. The whole group of water that's sitting there all combined together, even if it was recently diagnosed or if it was diagnosed 5 years ago, that's the prevalence. Now you have a drain in the bathtub. If you cure a patient, or if they die, or if they just don't have the disease anymore, they come out of the prevalence pool in the bathtub. And so that's important to understand, because prevalence is it's the constant look at what's going on currently within the community. Again, incidence is new cases, prevalence is active cases within the community. Why is that important? Well, we've learned in the old days, when we didn't have great technology to assess the cornea or assess the disease, we used to think that the prevalence of the disease of keratoconus was 1 in 2,000. And you can see it on this study over here, reported by Danielle Godefroeg out of a Netherlands study of 4.4 million patients. It's the entire country that was used. They used a mandatory health insurance database. While not the most perfect way to assess a disease, they actually had data, and they actually had everybody in the same electronic medical records, and they could look up the incidence and also obviously the prevalence of the study. And what they found out here was that the prevalence in the Netherlands study of 4.4 million patients, the general population prevalence, so the number of patients that actually had the disease was 1 in 375. The incidence, new cases, was 1 in 7,500. And so the conclusion from the study was that both the annual incidence and prevalence of keratoconus were 5 to 10-fold higher than previously recorded. What does that mean? That means we got to be on the lookout for it. We've got to use the right equipment to assess it. A secondary concept that I want to talk to you about when you're looking at keratoconus, so we talked about the histological basis and makeup of the cornea, is that you have a disease where you actually have thinning. If you go back to that OCT that we looked at, we know that the cornea gets thinner, and we know that it elevates. So when we look at the cornea, if a patient is lying down, or if you've ever looked at a cornea from the side, from a profile view of a patient, the cornea starts to bulge out. And so one of the things that we've learned is that the cornea essentially elevates off of what its best fit sphere was. Now, here's the question that I always ask everybody. Does a cornea get flatter or steeper in keratoconus? And the answer, as everybody on this call probably knows, is that a cornea gets steeper as keratoconus progresses. So if your cornea is getting steeper and your anterior surface is getting steeper, if the back surface moves at the same rate the front surface does, you're not going to have thinning. But we know that the cornea gets thinner. So if the front of the cornea is getting steeper, as when we look at most topographies, placido disc images, if it's getting steeper and it's getting thinner, that means the back surface of the cornea has to move forward faster than the front surface. So you have to have some sort of posterior corneal innervation in the disease to have thinning. Well, let's look at the equipment that we have out that's great right now. So many years ago, about 100 years ago, there was an ophthalmologist, Antonio Placido da Costa, who invented something called the placido disc. And you can see Dr. Placido da Costa on the left side, and on the right side, you can actually see Placido's disc, the original one that he invented, where a light came through the center and obviously reflected off of the cornea, and the images of the rings were superimposed, and they could measure curvature by measuring distance in between the rings. And so obviously, fast forward to today, and this is how a typical patient with keratoconus looks like with placido image ring problems. But one of the things that we've learned, there are a couple of fundamental concerns that we have about a placido disc. It measures curvature just fine. It does a very good job, but typically it only does a small diameter of the center of the cornea. Most placido disc images, and Bill Tullo will probably get into this as he is really the foremost expert on corneal measurement that I've ever met in my life. The rings don't go all the way out to the limbus, does not get a 12 millimeter image, so you don't get a full measurement of the cornea. The second thing is that to do a measurement, to take a picture, you have to have a camera. Well, where does that camera lie? That camera lies right in the center of the cornea. So there's no rings in the center of the cornea. So what happens is that every single corneal topographer that you've ever used in your entire life, the center part of the cornea is interpolated or extrapolated by the data in the periphery. And it's essentially guessing what's going on in that center part. So that is a fundamental flaw, that we're actually not getting real data. We're getting extrapolated data. And then number three, as you can see over here, the cornea of an image of a patient's eye when using a placido disc is reference-based. What does that mean? Well, if the camera is in the center of the placido disc, your patient's center of the cornea better be exactly lined up with that camera, or the image is going to be coming off axis. And what happens is that if your patient is not lined up perfectly in a placido disc imager, you run the risk of actually having a normal cornea look abnormal, or an abnormal cornea looking normal. And so because it is reference-based, you have a high risk of having true positives or false negatives when you run your test every single time. Last but not least, I want to talk to you about measuring curvature versus measuring elevation. And I know Bill is going to get into this a little bit more, but here's a simple concept. I call it the horse's saddle concept. And what we have here is a horse's saddle. And if you look at the elevation of a saddle, really the seat, the part where your behind goes right on that saddle, that's the highest elevated point of the saddle. The lowest point is where your feet go into the, I'm from New York originally, so I don't know exactly what those things are called, that your feet go, the stirrups, I guess. Your feet go into stirrups, that's the lowest elevated point. But the highest elevated point is the saddle, where you sit. You'll also notice that it's also the flattest point. Really the steepest point, the largest drop off in terms of curvature, is actually on the sides of the saddle. And so I want you to look at this cornea over here. and the image on the top right, not the topo image, but the actual cornea, if you look at the apex of the cornea is really pretty flat. But if you look inferior to that, the drop off of the cornea, that curvature is really steep. And if you look at the corresponding image below it, the big red spot is really the drop off, not the apex of the cone. And that's really important concept to understand, because if we look at this patient, if this patient was lying on their back, the apex of the cornea is the highest elevated point, but the curvature and the drop off is actually a much lower point. And with that, I'm going to turn this over to Bill, because he's going to get into the mechanics of this device called the OCULUS Pentacam that we all love, that I can tell you right now, the three of us cannot show up for work without this device. It's not to say that we're endorsing it, because I don't take endorsements from Oculus. I know Clark doesn't, and I know Bill doesn't either. But this is a device that we can't live without, because it does a great job of measuring the elevation and not the curvature of these corneas. And this is how the camera works over here. This is what the device looks like from the patient's view. One of the things I want to point out to you is that the camera on the Pentacam, you can see it inferiorly located over here. And that camera comes and spins around, rotates around in a 360-degree manner, and takes angled pictures of the cornea. So that center point that's typically left out by a placido disc is not by the Pentacam. Bill, I know you're going to go much deeper into the Scheimpflug camera system. You want to take it over from here?
Before you get started, we just have one question for you, and before I say that, I want to make a comment. That was an unbelievably clear and concise presentation to lead into this tonight. I've seen scores of them in the past, and it rates right up there as the best.
Thank you very much.
To build upon that, it's so interesting, the Dutch guys in this study that they have done. Do you think that that relates to us at all here in the U.S. As far as the same numbers for incidence and prevalence?
That's a great question. So my answer to that is that incidence and prevalence is never an absolute number, because the population is always changing, number one. And number two, many different practitioners typically have different equipment, and you can catch different people at different stages in their disease. Here's what I want the take-home message to be, and Bill and Clark, if you can chime in on this too. This is what I want everybody to remember. If you're going to remember 5% of this presentation, remember this part, and that is keratoconus is more prevalent and has a higher incidence than you think it does. It may not be that 1 in 375, it may be 1 in 500, it may be 1 in 600. We know the incidence and prevalence of the disease is much more common than we think it was in the old days, because we're learning more about the cornea all the time, and we're able to measure the cornea. There are so many of your patients out there that have astigmatism, that you can't get to a sharp 20/20 that may be keratoconus, not absolutely, but in the refractive surgery world, we uncover them because we can't let those people get into the operating room, because they do, they're going to end up with cornealectasia. And so we're seeking to uncover all those patients. Bill and Clark are also going to get into some other data that we have. But if you're going to remember one thing, don't remember the absolute number of 1 in 375. It may be different here in the States, but it is way, way, way more common. I would say that at minimum, we're talking about somewhere in the 1 in 500 range of the population. And it occurs in a much younger population than we used to think it does. I was taught 20-something years ago, keratoconus was a disease of the 2nd to 3rd decade of life. That is absolutely not true. I've seen patients myself under 10 years old have this disease. Clark, Bill, do you have anything to add to those numbers?
I think your points are excellent, Andy, about the prevalence. I think the numbers are not really as important as the concept. We have much better technologies today, and that's why we can detect it sooner. We understand the disease condition. And I think that today it's not acceptable to wait till patients lose best corrected vision. Before we had a treatment modality like cross-linking, there wasn't really a lot we can do with the diagnosis other than monitor the patient and follow their vision loss. But now that we have a treatment that can halt the progression of the disease, it's now become imperative upon us to do the best we can about detecting this disease as early as possible, even before patient vision. So I think your points are excellent.
Great. Just tell me next slide, Bill, when you're ready to move forward.
Okay, we can go to the next slide. So the Schleimflug camera located in the Pentacam tomographer can produce multiple different displays. I think one of the concepts we need to understand is that we're not looking at raw data when we're looking at these printouts. And this is a nice example of a quad map or a 4-map display that can be found on any tomographer, whether it's an OrbScan, a Pentacam, or a Galilei. They all produce similar scans. This is a beautiful example of a patient with keratoconus and a Pentacam 4-map refractive taken. And if you look at the 4 different maps, in the upper right-hand corner is that anterior elevation. And you can see the 2 flattened blue areas dissected by that orange-yellow saddle of elevation. And this is on the anterior cornea. If you look down on the bottom right, you see the posterior cornea with a similar geography where you see that inferior band of elevation coming out towards us. The fact that it's located in the same exact location on the front and back of the cornea indicates that this is true elevation from ectasia, and the fact that it's broken through to the front of the cornea means that this patient probably has some loss of vision, and which may be significant. If you take a look at the bottom left-hand graph, the corneal thickness graph, you can see that it's not a symmetrical round map. It's an amorphous, almost tripod-looking corneal map with significant thinning occurring. And again, if you want to look at the upper left-hand map, you can see the axial map of curvature with that inferior area of significant steepening, which would correspond to our areas where we would see when we fit a contact lens. This is inferior keratoconus. It's pretty classical keratoconus. And this is a patient who would have loss of best corrected vision in spectacles and probably requires some kind of intervention with contact lenses, which Clark is going to talk more about shortly. Andy, can I have the next slide?
And actually, Bill, can I just interject for a second? So,
sure.
Andy, could you, if you wouldn't mind, can you go back to the, yes. So I wanted to echo another point that actually Andy brought up a little earlier about how this is shape reference data when you look at topography, right? Most topographies are like that. And so therefore, most oftentimes where we think the apex is by looking at the topography portion, including here in the 4-map layout, your top left-hand corner is your topography. And you see that the area of apex is a lot lower than what the elevation would indicate, because the elevation maps gives you the elevation-based a data point for where the apex is. And the reason I'm bringing this up is because later on, I think Bill's also going to point out the fact that a lot of times looking at one specific keratometry index may not be as helpful, not only for contact lens fitting, but also for a lot of time monitoring keratoconus progression, because a lot of us are looking at that topography map, looking at the shape, and the area of the red is just showing you that the curvature is very steep. It's not actually showing you where the elevation is. And yet a lot of us use that Kmax as the only indicator sometimes to indicate whether or not the apex is getting worse, and therefore whether or not the keratoconus disease is progressing. So I think it shows very well here later on when we bring up that concept of why you shouldn't really rely on just one keratometry or keratometric indice. So I just wanted to kind of throw that out while we have the map in front of us.
That's a great point, Clark. So Andy, if we can go to the next slide, I want to focus primarily on the really powerful nature of the Pentacam and the software associated with it. It has something that is really revolutionary in the diagnosis of keratoconus, and that is a normative database. For all of us practitioners out there, we're accustomed to seeing normative databases in visual field machines. We're starting to see them in some OCT machines, and the software getting validated databases. But this was the first, and it still is the only Schleimflug imaging system that has a validated database so we can compare our patients to a whole host of normals and abnormals to see where our patients stand. This is called the Bellin-Ambrosio Enhanced Ectasia Map, sometimes abbreviated as the BAD display. And what this does, if you look at this display, the left-hand side of this display highlights the elevation changes both on the front and the back of the cornea. And it utilizes a nifty little trick that was developed by Michael Bellin called an enhanced ectasia display. And what this does is it takes out some of the data surrounding the thinnest point, because we know in a diseased cornea that has ectasia, that area around the thinnest point is going to be the area that's most affected and will become steep in nature. So if we discard that information around the thinnest point from the calculation of a normal eye, the best fit sphere, which is what the data you're looking at is plotted against, the best fit sphere will not change significantly, and the image of the graph you see will not change significantly. On the other hand, if you have an emerging keratocone where you have area around the thinnest point that is developing steepening, when you eliminate that data from the calculation of the best fit sphere, that area becomes visually enhanced. As you can see in this example, on the back elevation, which is the second column from the left, you can see as we go down from the top map to the second map that you see that red spot accentuates significantly. And what that tells us is that steepening is significant for ectasia keratoconus. This is a nice example because you can see in this patient, this is a patient who likely has perfect 20/20 vision. This is a patient that probably sits in the majority of our practices and goes undiagnosed for many, many years, because even a practice that has anterior positodisc topography would not pick up any significant abnormality on this patient, because all the disease is confined right now to the back of the cornea and to the volume of the cornea. The front of the cornea has not yet become involved, and that's why the patient's visual acuity is likely to be very good. But this patient has moderate disease already, and this patient is at severe risk for losing vision if there's no intervention done. So this was a nice example of a patient that over the years historically would not have had a diagnosis of keratoconus, would have gone on, and over time that elevation change would have broken through to the front of the eye, and the visual acuity would start to diminish. And then eventually a practitioner would pick up that this patient might have keratoconus, and then it would show up on positodisc topography, but it would happen years too late, and often too late for our treatment of cross-linking to restore the vision. While it still might be useful in halting the vision, it may not be helpful in reversing the damage that's been done. So the Bellin-Ambrosio Enhanced Ectasia Display was a groundbreaking device that uses this database. Now, if you look on the right side of the map, those two graphs toward the bottom of the right side of the map show you how the volume of the cornea is distributed. Those two graphs will graph the thinnest point of the cornea and show you in pachymetric terms how it thickens towards the limbus. And the two red lines you see are the actual patient data, and it's surrounded by those three black lines, which are two standard deviations from normal. We can see in this patient example on the bottom, the PTI graph, or the percentage thickness increase, we can see this patient's cornea increases in thickness at a much more rapid rate than a normal cornea would, which indicates there's an abnormal area of thinning. And that red line is significantly below the two standard deviations. And similarly, in the graph above it, on the CTPS graph, we also see the slope of that red line is significantly more negative than the normal slope of the black lines there. Even though it's within the standard deviations for most of the graph, it still is abnormal because of that negative slope. Probably the most powerful part, though, of this printout is in the very bottom right-hand side. When you see those 5 boxes and ultimately the final D box on the very bottom right, this is a regression analysis. What this does, it actually takes 9 different variables, everything from the back elevation, the front elevation, the thickness progression change, and several other factors, and it weights each factor individually to give us a estimation within a standard deviation value of normalcy. And we can see in this example, the final D value, which is the last number on the bottom right, is not only color-coded red, which we all know to be bad, but we can also see it's more than 5 standard deviations from normal. And yet this patient still may have 20/20 correctable vision. And this patient is clearly a patient with moderate keratoconus, yet this is a patient that often would go undiagnosed, a patient that can probably benefit from early intervention with keratoconus. So I think the groundbreaking difference with this display is it gives us a very high confidence in making the diagnosis. One of the problems historically with keratoconus, as Andy mentioned earlier, was the lack of standard methodology in reading these maps. I remember for the especially 20 years ago, we used to sit around a room and pass maps around, and everybody would have a different opinion on what the map would be. This gives us a standard methodology. It has about a 94% specificity and sensitivity. So while it's not perfect, it's incredibly accurate. Let's go back to the Bellin ABCD. Let's go back one slide to the grading system. This is also revolutionary for keratoconus treatment with cross-linking. One of the requirements for treating a patient with keratoconus is that a patient has progressive disease. We know that treating a patient with cross-linking that's not progressing, really the benefits may not outweigh the detriments. But if a patient is progressing, then cross-linking is indicated. Well, how do you know if a patient is progressing? It's a very difficult thing to answer. There's been many studies done showing that cross-linking is 100% effective because the lack of criteria for defining progression. The Bellin ABC system was the first system accepted by the North American Cornea Society and the European Corneal Society to show you the criteria for specifically defining progression of keratoconus. Excuse me, and it's based on sequential maps on the Pentacam. It takes 4 elements into account: the anterior radius at a 3 millimeter zone, the posterior radius at a 3 millimeter zone, the thinnest point of pachymetry, and the best corrected distance spectral acuity. It takes those 4 metrics and it grades them on a scale from 0 to 4. So as you can see in this example on the bottom right, this patient is an A2, B2, C1, D2. And that's the grading of each of the 4 characteristics. And now as over time, we can take these maps and watch this patient, and we can very, very specifically watch for progression that would tip us off to it is now safe to do cross-linking, and cross-linking is indicated. So this software, which is included in every Pentacam system, is essential if your patient is considering cross-linking treatment. Next slide, Andy. Now, I want to talk a little bit about IKA, and I know, Andy, you mentioned this group earlier in the presentation. This group, I think, is one of the most important groups in cornea study right now. Not only are we doing studies on important populations in the U.S., which is not well defined, this particular poster here was a poster that I was privileged to involve with, where we studied a population of children in Chicago public school system from grades K through 12. And we screened them with Pentacam analysis over time. Andy, let's go to the next slide. It shows a little bit of the data because we have a ton of data. We've screened to date almost 4,000 eyes, and I've personally read the majority of these Pentacams. And it's pretty incredible when you look at the data that we see. Number one.
Bill, before you go forward, I just want to point out that from a humanitarian perspective, the goal here was obviously to uncover the prevalence of keratoconus in a pediatric population. For those patients, this was an at-risk population, Bill. Am I right? This is a socioeconomically.
Yes, it's in a very urban environment and at-risk population. Yes.
And so, just to let everybody know, for those that we did identify as keratoconic and requiring cross-linking, we actually made that available to the patients free of charge, if I'm not mistaken.
That is correct, and you can see from the number of people that we screened and the number of positive results that we've seen. Now, we are working with the data to define exactly what is keratoconus and what is suspicion, but the alarming data shows that keratoconus is a disease that begins much earlier than the second decade of life, as Andy said earlier before. And we also know from the literature that is already out there is that the earlier the keratoconus begins, the more likely there's going to be loss of significant visual acuity. The earlier it begins, the more severe the disease tends to be, and the more imperative that intervention occurs. So in this population, it's really important that we learn exactly what is normal, because we have no normative data from young corneas, and this data set gives us an extremely valuable look at a young data set of corneas on the Pentacam. And the one result I'll point out here that is down towards the bottom is that when you look at both screening methodologies, both the ABC for progression and the final D on the Pentacam BAD analysis, when you combine the two for the students who failed both of those criteria was 5.2%, almost 200 eyes, or a prevalence of 1 in 20 keratoconic suspects, which is quite amazing when you look at that. And if you think about that you have 1 in 20 children that are at risk for losing vision and that need to be monitored closely, it's really eye-opening, and it's something that's not being done. And that's why this type of technology is really important to have available to these populations. We don't worry so much in the 50 and 60-year-old populations whose corneas are already naturally cross-linked and they're not going to progress. These are the kids that are at risk for losing vision. So I'm really excited to be involved with IKA and doing things like this. You may think that sitting and reading 4,000 Pentacam studies would be monotonous, but it really isn't. It's just such a wonderful, wonderful thing that this group of people are doing, and I'm proud to be part of that. But it highlights how common this disease really is and how often it goes undiagnosed. So we can go to the next slide, Andy. So early detection is really requires these advanced technologies. If we're only looking at normal topography by placido disc, and we're not looking at the volume of the cornea and the back of the cornea, we're going to miss this, and we're going to see it much later in its natural course. So it's really important to have these technologies available to these, especially at these high-risk, at-risk populations. Next slide, please. Excellent. So I'm going to introduce Clark in just a moment, because again, the point of the detection is now that we have this treatment paradigm, we have corneal cross-linking that's been shown to be safe and effective, even in young patients. It's really crucial and important that we identify these at-risk eyes as soon as possible, so we can preserve this vision using cross-linking. Next slide, please. So Clark, well, I'm going to bring you into this slide because I think this is an area of your expertise, and I know Avidro has FDA approval for cross-linking in the U.S., and I believe they're the only company right now with FDA approval for cross-linking. And when you look at the study that they've done and the criteria they use, do you want to talk a little bit about this criteria as compared to how we look at it ourselves today?
Sure. So, I mean, again, most of the publications and most of the cross-linking studies, even overseas, have adapted pretty much similar criteria. And that is, trying to, when we look at, I think when clinicians, especially in US, look at these criteria on the face value of it, we think, oh, that's such small steps. But it goes back to, I just want to remind everybody, sort of goes back to, again, what Bill had said, and that is early detection. And in order to achieve the goal of early detection, we must make sure that the steps that we're taking, the intervals that we're counting as progression, is not a large one, because now that we have cross-linking, we are able to help with patient to preserve vision without having to worry too much about unnecessary loss of vision, because we can treat them. So if you look at the criteria, most studies shows either over a period of time of 12 months or 24, and if any of these following criteria exist clinically, such as over 2 different time points, of course, within that 24 months period of time or 12 months period of time, such as either 1 diopter steepening of the, and Andy, you may want to just share this top share mode back, but such as 1 diopter of steepening in the keratometry in the steepest K, and as well as half a diopter, 1 diopter of increase in also the cylindrical or astigmatism amount over those two different time points, as well as spherical equivalent of 1 diopter cylinder obviously is half a diopter of myopia. So again, you may think, oh my God, that's such a small amount. How is that being used as qualification of progression? Again, the goal is to make the steps smaller so that we can put patients through different testing to make sure that we gather as much data as possible. Because we may only have topography in a private, you may only have that in a private clinic. If you don't, maybe you're going by your phoropter lower order aberration findings, such as the astigmatism, such as the myopia. And so if that were the point that raises your suspicion, then, referring to, a secondary care practice or practice that offers cross-linking that would have the instrumentations like a Pentacam oculus or other Scheimpflug imaging, potentially even in the future, testing the biomechanical strength, maybe even also, things like epithelial thickness mapping from an OCT, for example. I'm not, in the future, I think these are all in development, which are things that we could use. And another criteria that some studies, actually most studies have used, although it's not the most common one in my experience to qualify for progression because of the advancement in contact lenses, and that criteria is if you have enough change in the radius of curvature in the BOZ or the posterior OZ of a corneal GP lens. And I said that because a lot of patients are nowadays, when we talk about contact lenses, in a more bolting style type of contact lens, such as a scleral lens. And therefore, that sort of base curve change doesn't apply as much. Andy, are you still there with the screen? Can you bring back the presentation?
So Clark, let me ask you some questions while Andy's working on that. So I think what I see when I look at those 4 criteria and I look at Kmax, which was another criteria that was used in the majority of the cross-linking studies throughout the world, what I see with those 4 criteria in Kmax is they're all not very repeatable and not very easy to define as compared to the Bellin criteria for progression. What's your thoughts on Kmax and also the difference between, as that criteria mentions here, an increase in manifest refraction astigmatism versus corneal astigmatism?
Right. I mean, again, because what we talked about in terms of, keratometry, a lot of times, especially in your topography, in that first slide that you had introduced, Bill, a lot of times that keratometry is a reference to the contour, the shape. And then where the drop off is the most shows up really, really warm or red in our North American, topography scale, because other countries may use a different color scale. So that typically tells us, that it's really steep, and that's where the Kmax is. But again, it's not truly elevation based, and so your Kmax is going to be a little off in the value that you actually get. So I think, of course, if the progression is really aggressive and you have large amount of change in your keratometry, that's obviously, I think, most instruments do a really good job. And so that, can be considered as very realistic in terms of the qualification of progression based on just a Kmax. But if the movement is really small, let's say you went from 48.5 to 49.25, because in our clinical trial that I worked in, you have to at least be, be at least to be 3/4 of a diopter difference in 2 different exams. And so let's just say you went from 48.50 to 49.25. That's barely sort of meeting the requirements. So I would certainly love to combine with other risk factors in that regard to look at, myopic shift, to look at astigmatism, maybe even thickness changes, because some study uses about 30 micron difference thinning as a criteria to diagnose progression as well. So the more subtle they are, each indicator, the more I like to see multiple risk factors changing rather than just one, which is why it's very important to look at this ABCD staging, Bill.
So Clark, the last slide I'm going to comment on, I'm going to turn it over to you, is this is an example of the keratoconus progression ABCD staging progression. And I think what this highlights really nicely is there has been significant progression in this patient on the posterior back radius. And that's justified by that second column. If you see, the three exams are in beige, green, and brown. And the first set of beige, green, and brown is the anterior cornea, which hasn't changed significantly. But you can see the posterior cornea in this patient, that green bar that shoots way, way up, way past the 95% confidence interval for keratoconus, shows a significant progression, which now indicates the need for treatment, which is shown by the brown graphs there of the patient's findings after treatment. So I think this kind of software is really valuable to make sure that we're not recommending patients for cross-linking who may not benefit from it, and that we are recommending patients that really will.
And the treatment here that took place for the third exam, between the second and the third, which is the green and the brown, is obviously cross-linking, which we're going to talk a little bit about. But I do want to point out the most important thing in this patient's care, which hopefully we will do going forward in the future, is the very last column where you're seeing that the very last set of beige, green, and brown, where the vision stays the same. Right? You don't want that bar to keep going up before you decide to do something about this disease progression. In this case, this patient was properly documented at the very earliest sign of progression, and whereby cross-linking was provided. And so best corrected visual acuity was able to stay the same. And think of the impact that we can make in our patient's life when that happens, and whether or not we're going to provide contact lens rehabilitation. That's something that patient really appreciates, that we are able to help them to preventatively stop a progression of a disease so that their vision gets to stay the same. And if we go to the next slide, you'll see that I just wanted to show a quick case of a patient, a 20-year-old male, so very young. And likely, we know just statistically by age that the progression of the disease is going to be much more aggressive compared to someone who's, say, in their late 30s, early 40s. Not impossible for people to progress at any age, even into their fourth, fifth, sixth decade of life, but much less likely. So if you look at the progression with the Pentacam, it's able to give me to let me compare multiple time points. In this case, we compare just two different time points a year apart, and you can see that the difference map, the subtraction map at the very right-hand side shows you that there is and I apologize, the next slide, I'm talking ahead of myself. So in this case, in the left eye, you could see that this patient came back a year later, having had cross-linking treated in the right eye and was lost to follow-up. And you could see that there's actually, in the subtraction map, in the very last map, that there's progression, because again, this patient is young. So not only can Pentacam be used to compare and use, whether it's using ABCD or two different points, or even 4 different points of comparison to show me if the patient is progressing, whether or not cross-linking is needed, could also actually help me monitor a small group of people who, after, despite cross-linking, will continue to progress. And I can also compare those different time points to make sure that their progression continue to be arrested in terms of keratoconus disease. So if I go to the next slide to show you that obviously the goal is, if we could prevent, we could stop disease in its track and continue to monitor to make sure that we don't let the small group of people who can continue to progress after their first corneal cross-linking treatment to slip through the crack. But obviously there's going to be, always going to be a group of patients who may be too severe to, at the time of diagnosis, to be provided cross-linking, at least our current limitation to cross-linking. Or maybe they already developed a central scar, and so even with cross-linking, their visual potential is not going to be protected or preserved, and they may progress towards keratoplasty, which is obviously something that we're trying to prevent, especially with the help of contact lenses. And sometimes with repeated graft failure, not as common in keratoconus patients, but it can occur, especially if they have associated underlying autoimmune diseases, or even some sort of cicatricial condition. May not always occur again with keratoconus, but again, it's possible. So with repeated graft failure, you'll see a photograph of a K-Pro in the next slide. That may be a procedure that sometimes will be needed. And you'll see that coming up in the next slide. And what I want, in case you haven't worked with patients with K-Pro, it typically, or Boston keratoplasties, it's a synthetic, it's got a synthetic optical instrument in the middle that is basically can be, we do a cutout in a graft tissue, and then the optical stem will go through the cutout, and then the entire complex can be basically transplanted onto the eye, just like any normal penetrating PKP procedure. But because most of these patients do have some sort of desiccating disease, ocular surface disorder, like I say, cicatricial diseases, or even maybe post-herpetic infection that the cornea just is very difficult to take, and they go through multiple graft failures. But because of that, it's been found that a soft contact lens covering the entire ocular surface, a soft scleral lens, may help to prevent stromal melting or even desiccation and Delin formation. And therefore, you see the edge of a soft lens, a soft scleral lens on the ocular surface. While there are ocular surface profiler that can scan the entire ocular surface and help you create a soft lens, most of the time we're using software like that nowadays to create gas permeable lenses such as corneal GP or scleral lens, which is what Bill and I are going to show you in the following slides. And so, you may ask, well, do I really need, what can something like a topography or a tomographer like a Pentacam help me in terms of contact lens design? Well, first of all, we are very adapted to looking at topography at the very least to determine what kind of geometry we're dealing with post-corneal transplant, for example, obviously also pre-corneal transplant. But in cases just continuing the topic from a corneal transplant, you could use the cross-section Scheimpflug image to kind of explain the irregularity where the junction is and determine what size of lens you want to use if you are going to do a corneal GP. You can look at the topography such as the one that shows you a very centrally sunken graft to decide, well, I'm going to do a reverse geometry corneal GP if that's what you want to go. And in the next slide, you'll see that and these are all my patients, by the way, they're real life patients, real Pentacam from a patient's eye. And this is a patient after corneal transplant where you can almost see where a corneal, if you were going to do a corneal GP, just looking at the topography, which again is the top left-hand corner, you can do even a bitoric GP. So these instruments, even without the software to guide you in designing a corneal GP or scleral lenses, can still be very helpful. But let's get into a program that the Pentacam actually offers. Many people may not know the ability. We'll see that let's actually stop and talk about this slide very quickly before we show you the externally linked program that can help you design lenses. I apologize, Andy, I don't mean this one. Let's go to the next one that you actually just showed. I'm sorry about that. Okay, so can contact lens impact the natural course of keratoconus? We talked about cross-linking being able to do that, but what about contact lenses? So there are actually a few studies out there that shows you that utilizing a contact lens properly can defer the need for corneal transplant greatly. And this is one of those studies from University of Michigan. And it shows you not just scleral lens, but also corneal GP. Both of them decrease the rate of keratoplasty compared to patients with no contact lens wear at all. Much more reduction if you're wearing a scleral lens versus a corneal GP, but I think we know that, especially because severity of keratoconus, the more severe you are, it is possible that the less tolerance you may have to the instability of a corneal GP on the eye. So again, if we then proceed to the next slide, I believe we're going to get to there. And here I just basically, Andy and Bill and I want to show you that because of the study that I just showed, again, don't just focus on one type of lens. There are many different type of lenses, and we must work very hard at matching the feature, the pros and cons of each lens type to the lifestyle and the needs of a patient. And that may include a soft lens, a soft custom lens, a soft custom lens for keratoconus patients, maybe a corneal GP, maybe piggyback, maybe hybrid, and maybe scleral. There's not one lens that covers the entire spectrum of keratoconus population. So it's very important to remember that. So now, how do we design lenses if you don't have a diagnostic lens fitting method available to you, let's say, in your clinic? So there is a new tool, and what I love about Pentacam is their ability to continue to invest in research and be able to expand the clinical tools that are available to clinicians, such as the corneal scleral profile, or what they call a CSP. So by having patient assume you're taking 5 captures, looking straight ahead, side to side, up and down, once quality images are being captured, and the instrument will tell you whether or not you meet the quality criteria of each scan. Once they're captured, they're stitched together to form an ocular surface profile. And then if you go to the next slide, you will see that we are able to, there are different software that is linked, that the Pentacam allows you to link, obviously depending on your relationship, your own working relationship with which laboratory partners that you want to partner up with. And remember, it's not just for scleral lens, but also corneal GP. So in this case, let's highlight because it's on the screen, let's highlight the laboratory called Wave. So if you click on Wave, after you export your data into the contact lens manufacturer's software, in the next slide, you will see that after you do that, you can decide if you wanted to design a corneal GP. You can decide if you maybe want to design a scleral lens right from the start. And obviously, you're going to first enter the a contact lens refraction, meaning the base curve of the lens and the total power. You'll have to enter that. You'll also ask you, which actually shows up a little bit better in the next slide. So Andy, if you could click next for me. You'll ask you to enter your HVID or your white to white, which is your corneal port diameter, and the lens diameter that you then want to create, and the amount of apical clearance that you would like to have. For example, if it were a scleral lens, you may want to enter 250 or 300 to start. That may be pending your preference. I think anywhere from 200 to 300 may be reasonable to start as your first apical clearance. And then you will determine whether or not you have covered the limbus enough, or if you want to make a bigger lens. And then in the next slide, you'll see that the next step asks you to check to see to make sure that there's no scleral impingement, that the scleral zone fitting or not extra toricity, that you may have to open the lens design up to either a bitoric on the back surface or quadrantic, or even actually allows you to section into 8 slices to make different toricity in each of the 8 slices. And once you are happy with that, you'll take a look and adjust overall sac height to see if you want it a little more, a little less clearance, and whether or not you like the toricity that you have in the lens that you just designed, and whether or not you enter the proper requirement like a power and your HVID that we talked about, and then you'll hit send and the lens will be created for you. Now, I know Bill have very recently just started using this program as well. Bill, before I talk about the impression, do you have any feedback on what your experiences have been like?
Yeah, I think the value of this that I've learned in the very beginning process of using this is the critical data that I could not supply the lab with to make refinements on the lens. In the past, when I talk to most laboratories that make scleral or RGP lenses, they tell me that the average practitioner takes 2.5 to 3 lenses to fit a patient, which is a lot of chair time, a lot of waste, and I think I know that with this program that we can make a simplified process of fitting sclerals. When you talk to people who are starting to fit sclerals, a lot of people start and stop because of how complex it does get. And even though the consultants at the laboratories are often very helpful, you can't really give them the data they need to be as good as they can be. This program and this device allows us to really see what's happening, not only in the design phase, but in the fit phase. So I'm really excited about having this kind of data. I'm looking forward to getting that 2.5 down to below 2 to about 1.5, so that we can start fitting patients with one lens without having to make change after change after change. So I'm really excited that this is going to simplify and bring scleral lenses and RGP lenses back to the majority of practitioners that have abandoned them or never really started using them, because the patients are so underserved and they can really benefit from these lenses.
Yeah, and what I like about it is the fact that you have all these functions within, within one instrument, so that it's multifunctional and decrease the footprint in your office. But obviously, everyone would have to decide, for the square footage of your office, what kind of instrument you want to put in. So there's still going to be times that I think that, in my opinion, currently the scanning software still does not achieve the type of precision that I need on some of the really complicated patients. And so I, again, don't want to just be, product focused. I want to tell you that there's still a lot of times in Will's Eye in my cornea service that I still utilize, technologies like this iPrint, where I can take an impression of the ocular surface and then send it in to have this 3D scan, not 3D printed, 3D scan. And then therefore it goes, the toricity of the edge of the PC goes beyond just the 8 slices that I was talking about and highlighting in the software. It actually goes to as close to point by point that you can get. You can imagine the amount of toricity changes that you can cover in a design like this. So I still find something like this to be very helpful for me. And I'm very fortunate that I have all these technology available to me in the cornea service. So don't forget that that's also a possibility. But the reason I want to highlight these complicated scleral lens design, whether from the software that you just saw or the impression, is if you go to the next slide, which is my last slide, so hang in there with me, is that I've actually talked to some laboratories, and I'm sure you have patients who, once you put on the contact lens, whether it's corner GP, your hybrid, your piggyback, or your soft custom, or your or even possibly an iPrint that I'm showing you, you think, well, it fits really well. Why is it that this patient, and without any type of corneal scarring, why is this keratoconus patient, giving me a suboptimal visual feedback on the chart? Or maybe they're reading really well, but they're telling you, hey, when I go out at night, I know you're telling me that I'm seeing 20/20. I don't feel like I'm 20/20. Why is that? Again, some studies have shown that if you, obviously once you correct as much irregularity as we can anteriorly, the residual higher order aberration is going to take effect, right? Whether it's from your posterior elevation, misaligning with your anterior elevation, and therefore once you cover up the anterior abnormality, you still have your posterior, or maybe it's lenticular. So I've actually talked to labs that utilize a higher order, the aberrometry reading from Pentacam. Now, I have an eye trace as well that does ray tracing in Will's Eye. I also have a Pentacam, but obviously different practices are going to have different instruments. But I've talked to lab partners who said that they are finding, pretty good success at this sort of initial onset of creating wave-guided optics onto a scleral lens. So I think this is a space to watch out for in the future. So definitely make sure that I like to continue to have this kind of discussion if we can in the future, and hopefully we'll have more information to update you in the future. So I'm going to throw it back to Andy and Bill to give us a very quick summary on where you think the future of our care for keratoconus patients is going to be or become.
Well, thanks a lot, Clark. That was great, Bill. Thanks for everything. Again, the future of keratoconus, one of the things that I've learned, Clark, is that what we do with keratoconus care, it never stops progressing. It gets better and better and better. We've seen impression.
I think we lost Andy.
That's the fun of doing live transmitted lectures, right? You're going to run into these issues that I see on TV when reporters are interviewing each other. I feel very important right now to have one of us being frozen. So why don't I have this throw back to you, Bill? Why don't you pick up where Andy ended?
Sure. I think the future is in us looking for the disease versus the disease finding us. I think that one of the things that I do specifically whenever I have a keratoconus patient, I encourage all their family members to come in and get examined with the technology that can detect this early, whether it's siblings, whether it's parents, whether it's children or grandchildren. We really want to look very carefully since we know it does run in genetically in families. But I think the care is expanding with all the different modalities of contact lens fitting, with treatment of cross-linking, and even with the improvement in keratoplasties. I think that it's just an exciting future for patients with keratoconus that really didn't have a lot to look forward to in the 70s, 80s, and 90s. And now we have really a lot of great options to help preserve their vision and improve their vision.
And Andy, now that you're back, before I throw it back to Craig, our beautiful moderator, do you have any departing words to share about IK, just to make people know that we're still here with them, even if we're not on a webinar, but they can reach out to us?
I don't know if you heard what I was saying, but I gave one of the best presentations. Couple of things. Number one, www.keratoconusacademy.com is the website. Keratoconusacademy.com, keratoconusacademy.com. Go there. You can register. We want to educate everybody. It's a free registration. Please go there. We want to get your information so we can send stuff out to you. Number two, again, if you're going to remember a couple of things that we talked about tonight, you got to remember to measure not only the front, but also the back surface of the cornea. The Pentacam gives that information. Screen those younger kids like Bill was talking about before, because the disease is happening at a very young age. You want to treat as aggressively as you can within the parameters of the treatment guidelines. Like Clark was talking about, there is a wide variety of contact lenses. Don't ever forget GPs. GPs are great lenses. You have to fit the right lens for the right patient. Things are going to get better with time. And one of the last things I want to talk about, because OCULUS Pentacam, there is a version of it called the XL, the AXL, that actually measures the axial length of the eye. And that's important because a lot of people are doing myopia management right now to measure the axial length of the eye. One of the things I want to point out to you, I've seen 3 or 4 patients in my career where patients, these were kids that had keratoconus, that their doctors didn't uncover it, and these kids were put into Ortho K lenses, and their corneas were flattened by the lenses, and they progressed for years where their vision was not really a sharp 20/20 at any point in time with their Ortho K lenses, but because they were wearing Ortho K lenses all the time, their keratoconus was being masked, and the doctor was actually watching their keratoconus get worse without doing anything the entire time. If you're going to do myopia management, just remember that these kids, they get more myopic with time at a young age, just like myopes do. You better be sure that you don't have a patient with keratoconus before you start them on myopia management. You don't want to miss a disease. And with that, keep your eyes open. There's tons of keratoconus out there. We're all 3 always available if you have questions. I'm sure you can find our email on Google somewhere. People have put it up all over the place. And it was just a thrill to work with Oculus to put this presentation together. But please keep an eye out for those keratoconus patients. Craig, back over to you.
Okay, excellent, fellas. And please stick around, attendees. We have a number of terrific questions. And if you have any yourself, please write them into the question box. That was quite interesting what you mentioned regarding Ortho K, because in fact, we did have a question related to that. And in particular, the question was, will Ortho K treatment help or hinder the goal of early keratoconus detection?
Well, in my mind, I know that Andy has very strong opinion, but on this subject as well, in my mind, it will hinder because at least will delay the time of diagnosis, because when you look at the corneal contour of somebody wearing Ortho K, a lot of times, if we're not looking at if you don't have a baseline, let's say posterior elevation data from the time before they got fitted with Ortho K, you don't really know whether or not there's any progression, because the anterior portion has been altered by the orthokeratology or corneal reshaping. So you now have to wait for the cornea to bounce back after discontinuing contact lens wear until you think the anterior cornea bounces back to normal. So while it's not impossible to at some point diagnose somebody with keratoconus, if indeed that's what they have, it does delay the time of diagnosis.
the other issue, Clark, is that the majority of Ortho-K practitioners are not using a tomographer. They're using a topographer with a placido disc. And since they're not monitoring the thickness of the cornea, which again, Ortho-K shouldn't change the thickness of the cornea, it just alters epithelial thickness, they're going to miss it. And it's going to be a delayed diagnosis almost for sure, unless they're using a tomographer to screen the patients carefully, even while they're doing Ortho-K.
Craig?
Yes.
Yeah, I'm sorry. I'm running the presentation off of my computer, and I only have time for one more question, as I thought this was a 1-hour presentation. Could we get one more? I'm sorry. I hate to do this, but everything's off of my computer unless we can find a way. I have to shut my computer off where I am right now.
We could take questions without the presentation on, can we?
Right. Yes.
Definitely.
So Clark and I will sit and field questions, not a problem.
So
how do I set my, okay.
I will say though, folks, we might end up, unfortunately, if Andy's shutting this down, we might lose you. And if we do, we want to let you know that you will have contact from Oculus coming in the next couple of days, recapping your attendance this evening, and also be supplying to you a link to the recording of tonight's presentation, so you will be able to view it once again. I want to stay for a second, if I can, on that theme of children, and I'm going to build on the question that is being asked. How early do you use tomography or topography as just part of a standard care for a child? And do you do it even if they have what appears to be normal 20/20-ish vision?
I have heard I have read case reports, so it's an indirect answer. I've read case reports of a keratoconus patient, pediatric patient, diagnosed at age 6. So obviously it's possible to perform, tomography like Pentacam on depending on obviously maturity of the patient. You could have a 12-year-old who wouldn't open his or her eyes. So, but as young as the youngest case that I am aware of being diagnosed with keratoconus in the literature is age 6. So you obviously can do that at that age.
Bill, what do you think?
Patients in our Chicago study too, that young, that we've been able to measure too. It really depends on the cooperation of the patient. If they can sit still for 2.5 seconds, which most can. We've gotten valid scans on patients that young. So I know in my practice where I have the access to the Pentacam, I do screen my patients. It only takes my people 2 extra minutes to do a Pentacam screening on them. I may not necessarily repeat it every year, depending on the factors and what we find, but I now, knowing what I know from the study we did in Chicago, and at 1 in 20 patients have significant risk of developing keratoconus, as I do look at them carefully now.
It's really kind of interesting, because I think as we're looking at the management of children today, we're starting to make a case for maybe topography should be done really early, maybe axial length measurements should be done really early, so there's some level of baseline, and it might definitely impact the way the eye exam and the normal children exam will change in the upcoming.
Yes.
And when you look outside U.S., this is what is currently done in most countries, where eye care is portioned out a little bit differently, more centralized models, where there are centralized eye clinics. These kind of testing have been incorporated into routine pediatric screenings. We need to figure out how to do that in our model in the U.S.
Definitely. So I do have an interesting question here for you fellas, and that is if you were trying to monitor the progression of keratoconus, and if the patient is a contact lens wearer, in this case it's specifically asking regarding sclerals, do you have the patient stay out of the lenses to monitor the keratoconus for 1, 2, 3 weeks or so, or do you just measure it typically as part of their exam?
My protocol, so this is, did you say any age of keratoconus patient, or did you put a specific age range? I'm sorry, Craig.
No age at all, Clark.
Okay. So my protocol with So luckily, again, we're just relying on topography. That can be a confounding variable if you're only reading topography of a keratoconus patient. So if I let the patient come in wearing contact lenses, obviously they're coming in for their contact lens evaluation, and that's the primary job that I want to do that day to see if I need to make any changes, and I don't want them to just place the lens, and then have me take a look in the chair and have me take a look in 5 minutes. I want them to come in wearing the lenses as long as possible. So I would pay more attention that day. If like every 6 months, I tend to repeat Pentacam on my patients, so they remove their contact lens. I would, there is a field in my Pentacam that I can put in as comments. So I usually say, remove scleral lens, remove whatever, so that I know that I'm looking at a map a year later, that I'm looking at an exam result after a patient had removed a specific type of contact lens. In that appointment, I would pay more attention to my posterior elevation, to my potentially even pachymetry changes to see if I could have if anything raises my suspicion for a keratoconus progression, and if so, I will likely ask the patient to stop wearing lenses for a period of time, maybe 2 to 3 weeks, and then come back again for another scan.
Okay, great. Bill, we're having a little trouble hearing you.
Somehow Andy got me muted. I do almost the same thing. I'll keep it brief, but I see my patients for annual exams, at which time they come in wearing their lenses, their keratoconic lenses, and I'll do their contact lens work. And then at the 6-month point, they'll come back for just a cornea check, and I will have them out of their lenses, usually 24 or 48 hours, not quite the length of time that Clark must be better at talking his patients into going back into glasses than I am. But I'm usually about 1 to 2 days. I ask them to not wear their lenses, come in, we get a Pentacam, we ask them to have any issues with their lenses, and it's a minor examination at that point. But it is confounding. Wearing contacts, especially even more so corneal RGPs, can be really confounding to seeing progression accurately with any device.
Yeah, and before we leave that question, Craig, because it's such a good question, I also want to bring up the fact that the reason I say I would make a comment about which type of lens and when the contact lens that just got removed, when it's from, it's because if you make any modification to your contact lens, don't be surprised that the topography changes next year when your patient comes back. So I make very specific comments on all my Pentacam findings, exactly when the lens is from, so I can go back and make sure that I didn't change the posterior OZ before I compare the maps.
But Clark, wouldn't you agree that scleral lenses, because of their apical clearance, tend to have less effect on your Pentacam, even on the day you take out the lens, versus a flat-fitting corneal RGP?
Absolutely, but you have literature showing that keratometry changes post-scleral lens removal. You definitely still have data out there that shows, in fact, flattening, surprising, because I actually tend to think it's more regularization, so some steepening of the flatter area. But literatures have shown, such as studies from University of Montreal have shown, corneal flattening post-scleral lens removal is very possible, despite no apical touch, obviously. So because of that, it is still important to make sure you're comparing the same post-scleral lens removal if you want to be as accurate as possible.
Yep, I agree.
Okay, great. And I think, fellas, I want to ask one more question here. This is related to cross-linking. If a patient is 40-ish or 40 plus, and you think there might be progression in their keratoconus, would you still recommend cross-linking?
I'm sorry, Craig, can you repeat that? Can you repeat that question one more time?
If the patient is 40-ish, and noticing progression in their keratoconus, would you still be thinking about recommending cross-linking?
If I don't see, and if there's no inclusion criteria that meets keratoconus disease progression for somebody in that age group, I would be advising the patient of closer monitoring. Now, because it's not you don't have somebody who's 15 or 18. I'm okay watching potentially if this is somebody new to me every 6 months for a while. If it's somebody I've been seeing for 4 or 5 years and I can compare greater global trend, then I'm certainly less concerned about not seeing this patient in 6 months. Potentially, I could just compare annual exams. So risk factor, depending on the patient, does matter. The older they are and the less that I see any signs of potential progression, I don't automatically think that all keratoconus patients have to be referred for cross-linking.
And I would add, Clark, to that, I would be very cautious on what criteria we're using to call it progression in a 40-year-old, because it is unusual to see progression in a 40-year-old. It's not impossible, but it is unusual. And sometimes people looking at Kmax and calling that progression, where it's not real progression, it's just a different measurement from a different angle, can really make someone look like they're progressing. But if there's real progression in a 40-year-old, I would consider cross-linking them, absolutely.
Okay, great. So I'd like to begin with you, Bill. Do you have any closing comments as we wrap this up this evening?
No, I want to, again, take a moment to thank both Oculus and Barry Iden from IKA. I'm really excited about being able to, via IKA, help not only the children's database that we're going to be presenting and the data that goes along with it, and also helping industry find ways to fit these lenses faster, better, and cheaper, so that more optometrists can be fitting corneal lenses, scleral lenses, all types of lenses for patients with keratoconus, so they won't have to proceed to corneal transplantation. And thank you, Clark. Thank you, Andy. Thank you, everyone tonight. Really appreciate it.
You bet, Bill. Clark, do you have a couple words?
Same thing as Bill, and outside of that, I just want to thank everybody. I know over the 1 hour time, and to see that everybody's still staying online with us, I just really appreciate you taking the time out to join us. So hopefully we'll have another opportunity to interact. Thank you.
Excellent. And I want to make a point of thanking Oculus, of course, for sponsoring tonight's webinar. You guys were terrific. The time frame went by so quickly, it's hard to believe that it is 90 minutes at this point. So for Clark Chang, Andy Morgenstein, Bill Tullo, thank you so very much. Thank you to Oculus, and those of you that are attending, if you have any questions at all, you can either visit the OculusUSA.com website or contact Oculus USA at sales@OculusUSA.com. Thank you very much. Everyone be safe and good evening.
Good night, everybody.
Good night.